Good morning, everyone. Today is 10th December 2023, and I have been invited to speak on HELP syndrome at the MOGS Dr. N.A. Purandare teaching program organized by Sion Hospital. I would like to take this opportunity to thank Dr. Madhuri Mehndare and Dr. Pradnya Changade to invite me, and the President and Secretary of MOGS, Dr. Anaita Chauhan and Shailesh Kore. NA Purandare teaching programs are a super hit, and it is not only covering in Mumbai city, but also since it is online, many students join from all over India and also from abroad. So thank you for joining today early morning, and I will be speaking on HELP syndrome. The overview of HELP syndrome is going to be in the form of introduction, incidence, risk factors, etiology, pathogenesis, sign and symptoms, diagnostic criteria and investigations, management, complications, common differential diagnosis, and the take-home message. So to begin with, HELP syndrome, the full form is H stands for hemolysis, EL stands for elevated liver enzymes, and LP stands for low platelet count. Now, this word has been coined in 1982 by none other than Dr. Louis Winston, and it denotes a syndrome consisting of hemolysis, elevated liver enzymes, and low platelet count. And usually it occurs in pregnancy and more common in the third trimester between 28-29 weeks to 37 weeks. We commonly see such syndrome in patients with severe preeclampsia, and the recent report suggests that HELP may be a different condition, as 15 to 20% of those who develop HELP do not have either hypertension or proteinuria. Well, the incidence of HELP syndrome is 0.5 to 0.9% of all the pregnancies, and in preeclampsia it is seen to be in 5 to 7%. Sabai et al. Has reported a 20% incidence of HELP in women with preeclampsia, and these 70% of these cases are diagnosed in the antenatal period and 30% are postpartum. So let us understand what are the risk factors of HELP syndrome, and especially those patients who are preeclamptic or those who have previous pregnancy with HELP syndrome, or those who are multiparous and especially of Caucasian origin and a young woman are more likely to get HELP syndrome. Now let us understand the etiology and the pathogenesis of HELP syndrome. Now this chart will explain us appropriately how it occurs. So there is a aberrant placental development, and it is still under investigation, which results to abnormal maternal immune tolerance of placentation in early pregnancy. Plus, there is increased level of placental FASL in maternal circulation, and that causes lesions in the membrane separating the maternal and fetal circulation. There is release of inflammatory products from the placenta into the maternal circulation, and both this cause a systemic maternal inflammatory response activating the coagulation and the complement pathway. As a result, there is microvascular endothelial activation, there is dysfunction and further damage, which leads to widespread platelet aggregation and agglutination with a decreased amount of platelet measured in the complete blood count. And at the same time, in the liver, there is microthrombin formation. And at the same time, in the blood vessels, the RBCs are sheared as they flow through the damaged vessel, and that causes microangiopathic hemolytic anemia, and that is reflected in the lab diagnosis indicative of hemolysis. So you have a normocytic anemia with a high LDH and a high bilirubin level and a low haptoglobin. At the same time, there is low platelet, and because of damage to the hepatic circulation because of the microthrombins, there is damage to the hepatocytes, and that causes elevated liver enzymes. And all this come together to form what we call, known commonly as HELLP syndrome, because of hemolysis, elevated liver enzymes, and low platelet count. Now let us understand what are the signs and symptoms. So you have a patient who is pregnant. She has come to you in the antenatal period, more commonly seen in the third trimester, and she has symptoms of headache. There is nausea, vomiting. She has epigastric pain, abdominal pain, and more commonly, the pain is in the right upper side at the tenderness with liver. Plus, there is a referred pain to the shoulder, and the breathing becomes deep, and she has bleeding. Her vision is also affected, and she has got edema feet. So, all these conditions are camouflaging with pregnancy physiologically and in pathological conditions. And in some, they are also seen after delivery. So, we need to have a diagnostic criteria when we collect the blood of the patient. We find that in the complete blood count, and further, because of the hemolysis, the bilirubin is more than 1.2 milligram per dl, and the LDH level is also more than 600 units per liter. And we have SGOT-PT, that is aspartate aminotransferase, and alanine aminotransferase, which is more than 70 units per liter, and the platelet count is low, less than 1 lakh. Now, the further classification of HELP syndrome is there in 1, 2, and 3, which is based on Mississippi and Tennessee classification. You can see that it will depend upon the platelet count, the AST or the ALT level, and the LDH level, which is less than 50,000, which is more than 70 international units, and which is more than equal to 600 international units per liter in the Mississippi classification, while that in Tennessee classification, the platelet count is less than 10,000. So this is what is the difference. Or rather, sorry, it is less than 1 lakh count. In HELP class 2, here the count has further between 50,000 now to 1 lakh. And the AST or ALT is more than equal to 70 international units per liter. And the LDH is more than equal to 600 international units per liter. While in class 3, now the platelet count is between 1 lakh to 1 lakh 50,000, and AST or ALT is more than or equal to 40 international units, and LDH is also same, more than equal to 600 international units per liter. And there is one more class, that is partial HELP or incomplete HELP, where it is not applicable in the Mississippi classification, but in the Tennessee classification, you can see severe preeclampsia and one of the following, that is elevated liver enzymes or elevated or low platelet count, and that is what you have to understand. And there is absence of hemolysis, but that is not seen in this partial HELP or incomplete HELP syndrome. So to summarize, because of the hemolysis which occurs, there is an increased LDH level and a decreased hemoglobin concentration. And in the peripheral smear, you will find different abnormalities like spherocytosis, cystocytosis, reticulocytosis, anisocytosis, triangular cells, and Bohr cells. This is how the peripheral smear you will find, and they are represented here in the microscopic picture. The arrows can denote the cystocytes and the Bohr cells with a blue arrow, and triangular cells which are also seen with blue arrow. Now we have to understand what is haptoglobin. Haptoglobin is low, and that is a very diagnostic feature of hemolysis, and it is a preferred marker in HELLP syndrome. So what happens when there is hemolysis? The hemoglobin is reduced, and because of the hemolysis which occurs in the RBCs, that binds with the haptoglobin, and because the binding occurs, the level of haptoglobin reduces. Haptoglobin is very important for control of local inflammation. So you have a haptoglobin and hemoglobin complex, which are usually taken up by the reticuloendothelial system. But since this complex is at a very higher level, and that affects the kidney, that affects the liver, Kupffer cells, and because of the affection of the hepatic Kupffer cells, we have release of iron, we have release of amino acids, and there is a low haptoglobin. So this is a very important feature which we have to understand. Now, because of all these issues, the hepatocytes get gradually damaged. There is necrosis of not only the periportal but also the focal parenchyma, and a fibrin-like material gets deposited. You can see in the microscopic picture here, there is a patchy ballooning of surviving hepatocytes in zone 1, and there is coagulative necrosis on the lower aspect. This further damages the liver. It causes intrahepatic hemorrhage, and you can see that the Glissen's capsule enlarges and there are subcapsular hematomas, and eventually it cannot take over much more, and because of further damage and hemolysis, the rupture of Glissen's capsule can occur. Now let's come to the management. We have understood the incidence, we have understood the pathogenesis, we know the risk factors, we know the etiology of HELLP syndrome, how at the microscopic level it starts affecting the blood vessels, the RBCs, the liver. Now we need to understand, now the patient is bleeding, the patient is in a third trimester. So once we have identified the clinical features and we have immediate diagnosis with the lab investigations done, you have to understand that this patient cannot be managed in a small nursing home or a peripheral setup. It needs to be transferred immediately to a tertiary center where there are facilities of blood bank. And following admission, and once you have done the requisite consent taking and proper information to the relatives, you have to start the medical line of treatment. Irrespective of where and what the presentation of the patient is regarding the period of gestation. So you need to stabilize the patient. A wide bore angiocath, preferably 18 number, needs to be put, and we have to have at least 2 IV lines on both the hands, preferably. The blood is collected immediately for all the blood investigations which have been mentioned earlier, and you also need to cross match the blood and find the blood group of the patient. immediately catheterize this patient with Foley's catheter and note what is the color of the urine, whether it is concentrated. Because when hemolysis occur and there is extravasation of fluid from the intravascular compartment into the extravascular compartment, plus there is hypoproteinemia because of PIH or of any other cause, there is going to be affection of the kidneys. Automatically, the kidneys go in a normal mechanism to try to restrict the IV plasma volume. So you need to have an input and output chart. But you cannot forcefully flush and push in fluids into the patient's blood circulation. If you do that, it will be much more harmful. So you have to have an input and output and see that the CVP is maintained. Here it is very important because of the natural normal mechanism, the kidneys come into play and they restrict the fluids output. That is the intrinsic mechanism which you cannot prevent it, because then otherwise if you are going to give her Lasix or if you are going to open up, she is going to go in further hypovolemia and she will have further blood loss. So even if there is some amount of concentrated urine, do not panic. You maintain the input and output chart and see your vital parameters, maternal vital parameters like temperature, pulse, blood pressure, what is the respiratory rate, whether she requires further antihypertensives to be given in the form of if it is more than 160, 180 millimeters of mercury systolic, she might be requiring further good magnesium sulfate, or even you need to give her labetalol, or you need to give her antihypertensives which will help her. Respiratory assessment is very important. Assess the patient whether this patient is in labor or no. You have to have a proper understanding of per abdominal examination, the fundal height. You have to understand also that what is the lie, the position of the fetus, what is the presentation, whether it is vertex, whether it is longitudinal lie, breech or transverse lie, whether if it is a longitudinal lie, whether it is vertex, engaged, not engaged, with all the maneuvers which you have done. And you also need to assess the pelvis. It's very important to assess the pelvis so as to determine the pelvis adequacy if she is near term or if you need to terminate the pregnancy. So all this discussion will have to be done with the patient and the patient relative. And the most important thing is assessment of the fetus. So you need to check it on the fetal heart sounds on stethoscope or a Doppler. And if you have the facility of say NST, you need to assess also. And an immediate urgent Doppler will also tell you the fetal prognosis, the fetal viability, what is the beat to beat variability on an NST, what are the fetal heart sounds, whether they are good accelerations, and if there are any good accelerations, how much is the sustainability of this acceleration, if the patient is not in labor, and if there are contractions, you need to assess whether post-contraction bradycardia or decelerations are there, because all these things will be intertwined with your medical management of HELLP syndrome along with the fetal management and the well-being of the mother. So now, understanding this, you have to divide this patient less than 32 weeks expected gestational age, between 32 to 34 weeks, and more than 34 weeks. So first of all, if you have the patient with HELLP syndrome, you need to assess if it is less than 32 weeks, you need to have a good lung maturity of the fetus when it comes out. So administration of corticosteroid is must. And once you need to give a break of at least 12 hours, if you can. In the meantime, give her all the treatment of HELLP syndrome, which we will come to later. But in spite of that, if the patient's conditioning is worsening, you need to terminate this pregnancy, even though it is a preterm. And at the same time, If you do not have the facility, you will have to ship this patient to a tertiary center. But before that, you need to stabilize the patient and then send her. So you have 108 ambulance where a doctor is available and it is easily accessible in the city of Mumbai and in the various states of India. Now, if you have a patient who is between 32 and 34 weeks, there has to be an administration of corticosteroids here also. And if you find that the patient is eligible to be managed conservatively, well, you can continue that with the proper counseling of the patient, explain the pros and cons of this patient of continuing the pregnancy for further 2 more weeks, or allow more time for the fetal lung to mature. So, depending upon that, you can further wait, or if need arise, you need to transfer this patient to a tertiary care facility where there are NICU facility. However, if you feel that this patient cannot be managed conservatively and she is more than 34 weeks or 35 weeks or 37 weeks, then it's no point in waiting. You need to deliver this patient. And the same follow-up has to be done where you need to have a proper counseling, send her to a tertiary care center if it is 32 to 34 weeks, and deliver this patient if the condition worsens, as which is shown in the chart. Or if the patient condition is stable, you monitor the patient in a tertiary care center. This is as per the FOXI guidelines which have been made in 2007. As I said before, corticosteroids are to be given for fetal lung maturity, and also it will accelerate if it is less than 32 or 34 weeks. Plus, it also reduces the risk of intraventricular hemorrhage and NEC in selected cases of HELLP syndrome. So it has a dual advantage. From maternal condition point of view, there are proposed mechanisms where it diminishes edema, it inhibits endothelial activation, and it reduces endothelial dysfunction. Now we come to know the further treatment regarding the low platelet. So as we have discussed, as per the Mississippi classification, Tennessee classification, whether the platelet count is less than 150, like 1,50,000, or if it is between 1 lakh to 1,50,000, or if it is between 50,000 to 1 lakh, or if it is less than 50,000, you will have to decide accordingly and deliver the patient. If it is very low, it will be much more riskier for you to deliver this patient now. So you need to stabilize. You need to have a good facility of a blood bank, and a platelet transfusion is must. Preferably, if it is less than 1 lakh, do not take a chance. Do not wait for the platelet count to go down further. She will need fresh frozen plasma and she will need platelets to be given. And if she is a well-affording patient, you can give a random donor platelet that is also up to 6 to 10 units, and that has to be given over a period of 6 or 4 hours. The whole idea is that you have to reduce the coagulopathy and reduce the complications where this patient doesn't go further in DIC. Now, at the same time, when the hemolysis is occurring, there is a rise in the bilirubin level, and the bilirubin rise can be more than 1.2, or it can go to 4, or it can go to 8. So as the progressive elevation of bilirubin occurs, the hemoglobin also is falling and the platelet is also falling, and there is a further deterioration in the maternal condition. And in such situation, you need to give an exchange transfusion. And there are other methods like antithrombin and glutathione, which are also being given to correct the hypercoagulability, to stimulate the prostacyclin production, and to regulate the thrombin-induced vasoconstriction and improve the fetal status. So we have to understand all these things, and here it is better than heparin in that it does not increase the risk of bleeding. The worst scenario, in spite of your best of abilities of managing this medically, you have given her blood transfusion, you have given her platelet transfusion, you have given her fresh frozen plasma, you are monitoring the mother, but still it is somewhat not favorable towards an obstetrician or to the mother. The worst scenario can be acute kidney injury over a period of time. The kidney cannot take it, it cannot retain, and it causes constriction, it causes reduction, contraction of the kidneys, microscopic hemorrhages occur, and it is then irreversible acute kidney injury causing chronic kidney injury. It can cause further cerebral hemorrhage to begin with, and cerebral edema and then hemorrhage. And of course, the patient can land up with pulmonary edema on the other side, and worse situation, ARDS, requiring ventilatory support. And at the same time, in the liver, as I explained in the pathogenesis, now the Glisson's capsule cannot take it much more, and it has a subcapsular hematoma of the liver and it ruptures. And still worse scenario, there is retinal detachment, and the last thing can occur is sepsis. So you have to remember all these complications. We do not want our mothers to die with all these complications being there. Now let us understand the differential diagnosis. There are other three conditions where they are similar to that of HELLP syndrome, and we need to understand. One is thrombotic thrombocytopenic purpura, and the other is HUS. Now, all this presentation is occurring in the pregnancy period, but HELLP syndrome you will find more in after 37 weeks, while TTP in mid-trimester and HUS in postpartum. The CNS signs are more severe in TTP as compared to HELLP and HUS. However, the renal failure is more in HUS as compared to HELLP syndrome. And definitely, the hepatic dysfunction is more common in HELLP syndrome, as the name suggests. Fever may or may not be there, and purpura is more in TTP as compared to nil in HELLP syndrome, and slightly usually there, not there in HUS. Now you have to understand about the creatinine level, where the creatinine level are very markedly increased in HUS as compared to mild in HELLP and TTP, and the liver damage is more in HELLP syndrome as compared to TTP, and HUS there is no change. So this will differentiate us from all these things. And we have to always keep these two things in the back of our mind when we are treating a patient with HELLP syndrome. Also, we need to understand acute fatty liver in pregnancy. As you can see, it is more common in nulliparous and twins as compared to the multipara. But in acute fatty liver, here the jaundice will be common. The bilirubin will not be so much high in HELLP syndrome. It will be markedly raised in acute fatty liver of pregnancy. Ammonia level will be high. That will differentiate us from HELLP syndrome. Encephalopathy will be there, but in HELLP syndrome, you have less encephalopathy or nil. And as we are aware, the low platelet count will be seen in both. But the prothrombin time and the APTT will be much more prolonged in AFLP than in HELLP syndrome. And fibrinogen and glucose will be low as compared to that of HELLP syndrome. So treating the patient is very important. You need to monitor the maternal vital parameters. That is the take-home message. You need to reduce the risk of the serious complications, which we discussed now. We need to understand the fetal viability, the fetal well-being, and a proper per abdominal and a per vaginal examination to determine whether this pelvis is adequate or she might require a cesarean section. But as far as possible, nature is very kind. We try to deliver this patient vaginally as far as possible. So the blood loss or the cesarean section complications or the probability of this patient going in DIC is reduced. So once you have diagnosed a HELLP syndrome, You need to reduce the risk of complications and early delivery with corticosteroids. To wait for 12 hours or not to wait, that will be decided, as we do not want this patient to have much more morbidity. And you need to understand that still further assessment or a multicentric study is required, whether the benefit of antithrombin is going to be helpful to counteract the DIC in HELLP syndrome. So what is important, that to prevent all these things, you need to have a proper patient follow-up in the antenatal period. You need to check the blood pressure every time to see that her blood pressure is under control. And if she has a high blood pressure, she requires admission and treatment from eclampsia or pre-eclampsia point of view, and she doesn't worsen to go further in HELLP syndrome. And if she lands up in HELLP syndrome, see that you manage her appropriately, stabilize her. You need to give her proper platelets or random donor platelets or antithrombin and deliver her as early as possible so that she doesn't land up with any much more problem. So it's very important that the best way to find yourself is to lose yourself in the service of others. And that's what I have been doing it for the last 33 years in Sion Hospital, catering to poor patients. Sion Hospital, for all your benefit, is amidst the largest slums in Asia, Dharavi. And it is at the crossroads of Eastern Express Highway and Western Express Highway, catering to 22 peripheral municipal hospital. So you can imagine the workload, which is up to 10,000 deliveries a year, with 50% of such patients being transferred or directly referred to us. And the amount of work which we have and the experience which we have is phenomenal. So I hope you have understood today the whole idea about HELLP syndrome. I thank you all for a patient hearing, and I wish you all the best for your theory and practical exams, which you will be giving in the near future as a postgraduate student. Best of luck. And if I meet you somewhere, I'll surely say hi to you, and we will catch up soon. Thank you once again, MOGS, for inviting me for this wonderful session on Sunday morning. See you soon. Bye.